2 p.m. And I want to welcome everyone to this, our 58th Mrftt HIV STI session. This is a special session that we are devoting again to COVID-19 and HIV because there's still so much evolving data, information, so many new things that are informing both clinical practice and public health practice. So I just want to, I hope everyone had a great Diwali yesterday. It's one of our cherished national holidays. Thank you all for coming and having recovered from your celebrations. And we're going to get the ball rolling immediately by asking, again, welcoming Dr. Chris Behrens from the University of Washington, who is, again, an expert in infectious disease and medicine and practice. And he's going to talk to us about some of the new data that's come out that is informing, especially vaccination practice and in our person with HIV and COVID. So, Dr. Behrens, I'll turn the floor over to you.
Okay, thanks very much. It's great to be back. Wish I could be there in person as always. So let me just get this launched. We have the usual acknowledgements and credits to our sponsors. I have no conflicts of interest to disclose. Hopefully by the end of this, you'll be able to know a little bit more about how HIV infection impacts the severity of COVID illness, as far as we can tell, the safety and efficacy of the currently available COVID vaccines for people with HIV, and what are the recommendations around booster vaccinations for people living with HIV disease. So let's focus first on what impact does HIV infection have on the severity of COVID disease. And we have a few sources of information about that. I think the first one I'd like to highlight is a report that came out from the WHO in July. They have a database in which WHO is trying to collect as much information as they can from anyone who's willing to share this information about the history of COVID-19 from countries around the world, including key populations like people living with HIV. And the publication they put out in July was specifically focused on what are the risks of severe illness or hospitalization among people with HIV who contract COVID. And so they, as of the 29th of April, when they had the data they needed to publish this report, 37 countries had contributed data, but for the people with HIV, almost all of this data came from sub-Saharan Africa, specifically South Africa. So when we look at this data, it's worth keeping in mind that this is basically a South African cohort with very little contribution from other countries. In this report, this is just a breakdown of the demographics of the patients involved. And most of them were less than 65 years of age. Almost all were in the 18 to 65 year range. Most were female. There were some pregnant women, and there were a few healthcare workers involved as well. And to get to the chase, the final results, essentially, what they found that HIV was in fact a significant risk factor for severe or critical illness at the time of hospital admission, with about an estimated 13% increased risk that HIV conferred upon that as compared with people without HIV. Now, among those individuals with HIV who were admitted with severe or critical illness, these are some of the risk factors that apply that would increase that risk. Namely, age over 65 was a strong one, so was having high blood pressure, male gender, and diabetes. And these are the kind of risk factors that we have seen that increase the risk of severe COVID disease among people without HIV. So kind of a consistent finding in that regard. Now, they also looked at the risk of in-hospital mortality, actually dying from COVID in the hospital. And again, they found that HIV infection does increase that risk. And this is the finding that actually was somewhat widely reported in the news and social media, that because this was the first major publication that had found a significantly increased risk of mortality from COVID if you had HIV infection. The hazard ratio being 1.3, so about a 30% increase in the risk of dying from COVID if you had HIV disease. Essentially the same risk factors applied among those people with HIV that also increase that risk: age, male gender, history of diabetes, or high blood pressure. Again, risk factors we sort of already know about that exist in the general population. Now, what this report was not able to tell us much about was things like CD4 count or antiretroviral therapy, because those data aren't reported to this database they maintain. So that's, again, primarily data from sub-Saharan Africa. For kind of a different setting, we have also a large database in the United States that is tracking outcomes of COVID illness. And they have accumulated quite a large number of cases, over a million, nearly 1.5 million COVID cases. And of those, over 13,000 had HIV infection. And these individuals published a report just a few weeks ago about what they know about folks with HIV and their experience with COVID in the United States. And this comes from 54 clinical sites across the country, all of them adults. And similarly to what the WHO report found, HIV infection was, in fact, here in the United States, even after adjusting for all the potential confounders, age, sex, race, ethnicity, smoking, etc. They did find that HIV infection did increase the risk of death, of hospitalization, and of severe COVID-19 disease, as compared to people who do not have HIV infection. So again, a large database from a different kind of country, United States, showing the same result. HIV does increase your risk of mortality and severe illness from COVID. Now, among those people with HIV, they looked at what are the risk factors, just as the WHO had done. And the findings, frankly, were fairly similar in that, age was a risk factor. What was kind of interesting, though, is that if anything, being male seemed to be protective. It was females that seemed to be at higher risk for mild or moderate disease or severe disease. I have no idea why that might be the case, why we would see that difference in South Africa versus here. Perhaps we could think about that a bit more. And there was possibly an increased risk according to ethnicity as well. In terms of hospitalization and death, essentially the same patterns applied, with females being at higher risk and older age conferring generally a higher risk as well. Now again, that report didn't tell us much about things like CD4 count or virologic suppression, which I think are likely to be very relevant. We have to really look to some smaller studies for that. This is another study from the United States involving just nearly 300 people with HIV, also diagnosed with COVID between April and July of 2020. and they were looking at severe outcomes, defined as a composite endpoint of ICU admission, mechanical ventilation, or death. Secondary outcome, need for hospitalization. What they found were the following sort of risk factors that increase the risk of hospitalization on this slide. Again, older age, although it wasn't real strong, but here we start to see finally some data about the impact of CD4 count. And what we do see with the significant p-value there is that having a CD4 count less than 200 definitely does significantly increase the risk of hospitalization for people with HIV who have COVID, as compared with the reference of people with CD4 counts over 500. Outside of that, the sort of usual, already known, anticipated risk factors apply, having other chronic diseases. In this case, they found chronic kidney disease, chronic lung disease, and frankly, a high number of comorbid conditions significantly increase the risk of hospitalization in this cohort of people with HIV. Now, they also looked at severe outcomes. Pretty similar pattern we see. Low CD4 count, again, associated with increased risk of a severe outcome. Being older, associated with that as well. Having high blood pressure, chronic lung disease, and a high number of comorbid conditions. Again, not surprising, kind of similar to the pattern we see in people without HIV. This is a Kaplan-Meier graph just showing the overall survival curves according to CD4 count. And as you can see, the CD4 count less than 200 in blue, they have the worst outcomes, as compared with those with CD4 counts over 500 in green. That is statistically significant with a p-value of 0.05 for that. Okay, so let's move on and look at a different region. This was a study done in Spain, a retrospective cohort study that involved over a large number of people between March 1st and December 15th of 2020. And again, they were trying to look at risk factors for severe outcomes, and which consisted of a hospital admission for over 24 hours with dyspnea, tachypnea, hypoxemia, asphyxia, or hyperventilation, or death. And they basically found similar findings in the sense that CD4 count matters. The low individuals with low CD4 counts, less than 200, definitely had lower survival rates as compared with those with higher CD4 counts. Now, interestingly, this study also looked at whether individuals were virologically suppressed on ART, and that too fell out as a highly significant risk factor, in that those who were not suppressed, had ongoing HIV viremia, had worse survival outcomes. Essentially, they were more likely to die while hospitalized. And they even looked at whether the CD4 count mattered in those who were suppressed, and indeed it did. So it seems like CD4 count and virologic suppression are sort of independent risk factors for people with HIV. If you have a low CD4 count, whether you're suppressed or not, you may be at higher risk for a poor outcome. If you don't have virologic suppression, you may be at risk for a poor outcome regardless of your CD4 count. So this is interesting data. It's just one study, but a fairly large study, a large cohort from Spain. They looked at hazard ratios for other comorbid conditions. And again, you see kind of the same patterns as we do for people without HIV in terms of being having a severe outcome over there on the right. In terms of being diagnosed with COVID, they didn't see that really pan out so much in people with HIV, with the exception of autoimmune disease. But in terms of severe outcomes, again, metabolic disease really stood out. These are things like hypertension, obesity, diabetes, as did chronic lung disease and autoimmune diseases. Also, interestingly, neuropsychiatric conditions. So, what conclusions can we draw from these studies? Broadly speaking, it would appear that people living with HIV who contract the virus, who have COVID illness, appear to be at higher risk for severe disease and mortality as compared with HIV-negative individuals, broadly speaking. Now, risk factors for severe disease among people living with HIV include low CD4 count, detectable HIV viral load, and the same kind of risk factors that we see in people without HIV, specifically older age and comorbid conditions, including metabolic diseases like obesity, diabetes, high blood pressure, also chronic lung disease and chronic kidney disease. In the United States, we saw female gender and Black ethnicity possibly increasing the risk for severe COVID illness, again, among people living with HIV. Again, only here in the United States in one study. So I'm not sure if that will truly pan out as we accumulate more data. Okay, switching gears, let's talk about the vaccines for people living with HIV. What do we know about efficacy and safety of these vaccines? So let's start by looking at a report published about the Oxford AstraZeneca vaccine. This was a study looking at its efficacy in people living with and without HIV. And like most of the studies we're going to go over, they're using surrogate markers of efficacy, which involve measuring antibody levels against certain parts of the virus, or what they call neutralizing antibody levels. And occasionally we'll see some measurements, attempts to measure the T cell response to antibodies as well. So this particular one, these data come from a multi-center randomized placebo-controlled trial that was assessing the safety and immunogenicity of the AstraZeneca vaccine in people living with and without HIV in South Africa. They had 56 HIV-negative participants. They had 102 people living with HIV. Within each of those two groups, roughly half and half, were randomized to either the vaccine or the placebo. Now, the people living with HIV that were included in this trial were all stably on antiretroviral therapy with pretty high CD4 counts. Median CD4 count was about 700. And they measured the immunogenicity of the vaccine by looking at IgG or antibody levels to the full-length spike protein, the regional binding domain region, as well as broad neutralizing titers of antibodies that were measured at baseline, day 28, and day 42 after receiving this vaccine. And they also looked at the safety. So this is kind of standard stuff that was done in the sort of early phase studies of vaccines to try and get a bead on how safe were they, and at least how strong an immune response did they seem to generate in people who received the vaccine. And so what they found was, essentially they saw pretty much the same level of antibody response among people with HIV in this study as compared with people who were HIV negative. Whether you looked at baseline or day 28, right after the booster dose, or day 42, which is perhaps the most relevant, 2 weeks after that booster shot with the AstraZeneca vaccine. So really, if you look across, there's just no meaningful difference between the responses, which is very reassuring. People with HIV seem to respond just as well. Again, though, these were people living with HIV on treatment with high CD4 counts. That was to the full-length spike protein. If you look at antibody levels against the regional binding domain, also on the spike protein of the virus, similar story, essentially the same responses. And if you look at neutralizing antibodies, the ability of these antibodies to neutralize, they looked pretty much the same. They did this interesting thing where they tried to assess, what was the response like if individuals had already had COVID infection, and how did they respond? And not surprisingly, individuals who had had it before actually had a stronger response after the vaccine than did those who did not. That's a phenomenon we've seen in people with HIV as well. But I think the main point is that the individuals who received the vaccine who were HIV positive seemed to respond just as well, no matter how you looked at antibody levels, as did people without HIV. In terms of safety, this is kind of a busy slide. And you can, those of you who want to look at this slide later in detail, you can, but the broad story here is that the safety and reactions against the vaccine were more or less the same in people with HIV as was seen in people without HIV. Exact same kind of reactions, exact same kind of severity, no meaningful difference there. So that was relatively reassuring data from South Africa involving the AstraZeneca vaccine, again, in people with HIV on ART and high CD4 counts. We have a similar study that came out of British Columbia, Canada, and this study also involves people living with HIV who were on ART, also had high CD4 counts, again, roughly 710. So very similar in that sense, but a different population in Canada, and different vaccines were used in this case. Now, they use the same kind of way to measure immunogenicity or antibody response in the participants. They had 100 individuals with HIV and 152 control patients without HIV for a comparison. And this is just giving you a sense of what vaccines were received. Most of these individuals, both the HIV infected and the controls, received the Pfizer vaccine. Roughly 60% of the people with HIV got that vaccine. 23% got the Moderna vaccine, and 17% received the AstraZeneca vaccine. And then there were a few that got kind of mix and match individual, might have received the AstraZeneca initially and then got a messenger RNA vaccine. Only 8% of the participants in this study, received the vaccination series consisting of 2 shots of the AstraZeneca vaccine. So this is a little bit different in that we have most of our participants in this study receiving messenger RNA-based vaccines, but we also have a few who got the AstraZeneca. And it's kind of a similar story here. We see virtually identical antibody responses to vaccination broadly speaking, we're not really breaking it out by vaccine type in this slide, among people with HIV as compared with individuals without HIV. The ones with HIV are shown in black, the ones without HIV in gray. The convalescent is showing what happened to individuals who had already had COVID and then got the vaccine. And again, not surprisingly, you see significantly higher antibody titers among those individuals. And these A and B is simply showing what the titers were like right after that first dose versus after that second dose. And reassuringly, you see a nice, robust response after the second dose that is essentially the same in people with HIV as compared to those without. Now, again, these are individuals with high CD4 counts on ART fully suppressed. They tried to examine this question of whether CD4 count matters in terms of a response to the vaccine. And this is, I think, a very relevant question, and I'm glad they looked at it. And they did see a correlation. It's not very strong. The dotted lines give you sort of a sense of that, with the red dots being what were the levels of antibody titer after the first dose, the blue after the second dose. Essentially, if you do the math, do the calculations, having a higher CD4 count when you receive the vaccine is associated with a slightly more robust response in terms of antibody titers. Whether that's clinically significant, at least among these individuals, is not totally clear. Again, it's also worth noting that these were individuals who had relatively high CD4 counts at baseline on average anyway. You just don't see very many individuals on the scatter plot with CD4 counts less than 300, for example. So there was another way they tried to look at this data. How well were the antibodies in vaccine recipients able to block binding to the ACE2 receptor by the COVID virus? Same story, pretty similar responses among the individuals with HIV as compared with those who did not have HIV. And again, looking at that assay, same story in terms of whether there was an effect mediated by CD4 count. Yes, maybe, but not a real strong one. Higher CD4 count, more likely to have a higher titer of the antibody response. And lastly, they looked at neutralization antibody titers. And again, they saw the same phenomenon, basically no difference in response among people with HIV versus those who were HIV negative. And interestingly, they were able to look specifically at how well did the vaccines perform in people with HIV against the Delta variant. And of course, this is very relevant because this is a variant we are all dealing with at this time. And broadly speaking, we saw, again, the same story. Now, the plots look a little odd here. These are called violin plots. They're sort of like box plots, but they contain, they capture information about something called kernel distribution, which I can't begin to explain. Biostatisticians like violin plots because they provide more data at a glance. I like them because they kind of look like Christmas ornaments, and they've got me in the mood for the holidays already. But the bottom line is you want those Christmas ornaments to look less like fat bulbs towards the bottom and more like nice towers that are highest up at the top. And what we see with these violin plots is that essentially the same story. After that second dose of the vaccine, there really was a nice, robust response among people with HIV. That was really no different as compared with people without HIV in terms of their ability to displace that ACE2 binding domain. All right, and then they wanted to, they had a rather busy, complicated table in here looking at trying to summarize all these different risk factors and also break it down by which vaccines were received. And I'm going to highlight a few things for here. One is that, broadly speaking, HIV infection did not pan out as being any sort of a risk factor for a poor response. No matter which way you slice the data, no matter how you measure immunogenicity, and again, they used 3 different ways of looking at that in this study, HIV infection did not seem to reduce immunogenicity, broadly speaking. Again, these are patients on treatment with high CD4 counts and virologically suppressed. What did kind of pan out was that no matter which measure you used, receiving the AstraZeneca vaccine as both of your doses did not generate as strong an immune response as did receiving the messenger RNA vaccines. And that was a consistent finding. We saw that this is not a surprising finding particularly because we have seen from other data and other studies that the AstraZeneca vaccine just doesn't seem to be quite as strong as the messenger RNA vaccine. So really not that surprising. All right, let's look at some similar data that came from the United Kingdom. And this is specifically, again, about the AstraZeneca vaccine. And this study enrolled 54 adults with HIV. It was part of a larger study looking at the safety and immunogenicity of the AstraZeneca vaccine. Those people enrolled who had HIV, again, all on ART, all had undetectable HIV viral loads, all had CD4 counts greater than 350, median CD4 count about 700. So really very similar to what we've been looking at so far. We saw very similar results. People with HIV appeared to do just as well as those individuals who were HIV negative in terms of having antibody responses. The reason I included this study, and it is a preprint, by the way, so it hasn't yet made its way into the peer-reviewed literature, but they actually tried to measure T-cell responses using what's called an interferon gamma ELISpot assay. And reassuringly, they saw that the T-cell responses seemed to be just as good. And obviously, there's some reason in theory to be concerned about the T-cell response to vaccinations in people with HIV, because of course HIV targets and destroys T-cells. And so it's reasonable to think that, well, maybe we're seeing good antibody responses among vaccine recipients to date in people who have HIV, but there's a whole second part of the vaccine's ability to generate an immune response. It's not just the antibody response, the T-cell response is at least equally important. So it's good news that, at least in this small study, the T-cell response appeared to be just as good in people with HIV as those without HIV. Now again, these are people with high CD4 counts on ART, undetectable viral load. I'm not going to go through all the data here, but it's similar to the study shown before regarding safety and adverse events, essentially very similar profiles for safety and reactions among those with HIV as compared to those without HIV. All right, let's look at another study that was very recently published from the United States that is looking at the impact of the messenger RNA vaccine in people with HIV. And these data were collected a little bit more recently, between January and March of this year. And this was sort of a national study that tried to recruit people via social media. And those individuals who participated had antibody testing before they received a second dose of their messenger RNA vaccine. And it was a very small study. They have only 12 individuals, but I think there's this sort of interesting finding that I highlighted in the box there, that some of these individuals really did not mount much of an antibody response, 4 of them specifically that I've sort of highlighted in that box. And those individuals did seem to have lower CD4 counts, all of them less than 500, 2 of them less than 200. That's where you saw the poorest response. And this is despite receiving these messenger RNA vaccines, which again seem to be the strongest one. So obviously very small numbers, but there's this suggestion that we're seeing when we finally start to look at people with low CD4 counts that maybe they're not going to respond as well to these vaccines. There was a retrospective analysis of files done in Germany as well, looking at over 600 individuals there. And these individuals had received either messenger RNA, the AstraZeneca vaccine, the Johnson & Johnson vaccine, or sort of a mix and match approach. And in terms of the antibody responses in these, we see kind of some similar findings in that having a low CD4 count in this cohort was associated with lower antibody concentrations in response to the vaccine. So I think it's worth including this in our consideration, because whereas the study I just mentioned really only had a couple of patients, this one involved over 600 patients, and they too found this statistically significant difference. They found that the messenger RNA vaccinations performed better, and they found that having undetectable viral load also resulted in a higher likelihood of having a higher level of antibody response. Interestingly, in this study, female gender was an advantage as well. Having had a history of AIDS did not pan out, that's the very bottom row, did not pan out as being a risk factor for a poor response to the vaccine, which was kind of interesting, because we know that for a lot of complications of HIV, the nadir CD4 count is relevant, but having a history of AIDS did not fall out in this study as being relevant. They did try to see if CD4 count, CD4 count nadir, I should say, had any impact on the response to vaccination as measured by antibody levels. Again, we might have expected this. Like I would not have been surprised to see that nadir CD4 count predicted a poorer response to vaccination, but they did not see that at all. The nadir CD4 count didn't seem to matter at all. All right, and then there's one last study that was just presented a couple weeks ago of what's called ID Week here in the United States. This was a very small study done in San Francisco that simply looked at antibody levels in people with HIV who received either the Moderna or the Pfizer vaccine. And they did this by essentially looking at lab samples that had been drawn at the University of California, San Francisco in May of this year. They compared them to controls, people without HIV. They looked at the type of messenger RNA vaccine they received, and they were looking at these measures of immunogenicity as measured by antibodies to the receptor binding domain and pseudovirus neutralization test. So these individuals, they had a median CD4 count of 500 in the study, but there were some who were not suppressed, and mostly a male population in both categories. Interestingly, they found that there was a non-response in terms of surrogate virus neutralization associated with having HIV infection in this study. So just having HIV, again, very small study, was a risk factor, elevated the risk of not having an adequate antibody response to vaccination. And this was largely attributable to a rather surprisingly poor response to vaccination in people with low CD4 counts who received the Pfizer vaccine. They saw 7 individuals in this study with CD4 counts less than 200 who didn't have an adequate antibody response, but they did not see that phenomenon in those who had received the Moderna vaccine. That the phenomenon I'm talking about was only seen in those who received the Pfizer vaccine, suggesting maybe there's something about the Moderna vaccine that performs better in people with HIV, or at least in those with low CD4 counts. Now, they did see, again, as has been shown in prior studies, that having higher CD4 counts tends to correlate with a higher immunogenicity. That was replicated in this study. But again, what was most interesting, I think, about this study was that there was really inability to measure an adequate virologic response to vaccination among several individuals in the study who had CD4 counts less than 200 and who had received the Pfizer vaccine, but not the Moderna. Suggesting, again, maybe there's something about Moderna that is better for people with HIV who have low CD4 counts. This is just one study from one site, very small numbers. You know, I am not entirely sure that this will pan out, but I think it's, you know, as we accumulate more data, but I think it is rather interesting. So I'm going to conclude there. I have one other mention, thing that should be pointed out. All the studies I've cited to date that talk about, that try to measure the efficacy of vaccines in people with HIV are really looking at what we call in vitro evidence. We're looking at these surrogate markers in terms of antibody levels and pseudovirus neutralization and T-cell responses. What's really kind of lacking is what you might call the in vivo evidence of, you know, well, how well are they working in the real world, you know? And so I think the key question is, like, are we seeing greater numbers of breakthrough COVID infections in people with HIV who have been vaccinated as compared to people without HIV who have been vaccinated? And if so, are they having more severe disease than those without HIV? We simply don't really have those data yet. I mean, there was, you know, one of the vaccines out there, and it's not even being used very widely yet, the Novavax. They did report a very subtle difference, maybe in less of a response among people with HIV. But we just don't have those kind of data yet. And so it's important to keep in mind that a lot of what we're talking about is more or less theoretical, and it's not clear how that's going to play out clinically, at least not yet. So just to sort of conclude what we know about the efficacy and safety of COVID vaccines for people with HIV. These are kind of the conclusions I've drawn so far. Most studies to date have found that people with HIV with high CD4 counts and virologic suppression appear to respond just as well to the messenger RNA and the AstraZeneca vaccines as compared to HIV negative individuals. Again, this is as measured by T-cell responses and antibody responses. And we even have a small study that confirmed that this pattern appears to hold even against the Delta variant. So for people with HIV who have high CD4 counts and are on ART, the data so far suggests that, you know, we can sort of regard them, expect that they would respond to vaccines just as well as people without HIV do. The messenger RNA vaccines appear to generate stronger antibody responses in people with HIV than do the AstraZeneca or the Johnson & Johnson vaccines. Not very surprising, this is the same pattern we've seen in HIV negative individuals. Low CD4 counts and absence of virologic suppression appear to be risk factors for poor antibody responses to vaccination among people with HIV. Not a total surprise there. One small study found that people with HIV, especially those with low CD4 counts, appeared to respond better to the Moderna vaccine than the Pfizer vaccine, as measured again by antibody levels. And lastly, the clinical significance of these findings remains unclear, as data are lacking regarding the real-world impact of HIV disease on these COVID vaccines for people with HIV. So here, I think I'm going to stop and open it up to questions and discussion.
All right. Again, Dr. Behrens, thank you for, as usual, a fantastic and a wonderful presentation. So much. I mean, it's astonishing, really, in the period of time since our last conversation, how much new data there is and how much stuff there is to learn, because these are some of the questions that patients ask us all the time, you know, in terms of, you know, how well is vaccine going to work? Where's the evidence? And sometimes in the attempt to be reassuring, in the back of your mind, you start thinking, well, where's the data? Where's the data? Where's the data?
Yeah.
So it's really helpful to know that some of the data is starting to come out whereby you can actually make reasonable statements that yes, there is evidence to prove that, you know, the higher your CD4 counts, the better you do. And it's even it can be used as an adherence tool. Look, we're in the times of COVID. The evidence is proving that staying on the meds, remaining on the textbook, keeping the CD4 count high is going to reduce the risk of getting severe COVID, and the vaccines are going to work better. So that's even another message we can use to encourage our patients to be adherent. So I would just again open all the floor to anybody who might have any questions for Dr. Behrens or any comments.
So, Dr. Behrens, one of the vaccines not mentioned in what you spoke of today was Sinopharm, which also we got large numbers of here in Trinidad. Would you estimate as to where Sinopharm kind of stands in comparison to some of these others you mentioned?
The short answer is I have no idea. Sorry. As I recall, well, and I have no idea with respect to people with HIV. In the research I did preparing this talk, I just didn't come across any studies of how well Sinopharm performs in people with HIV. So it may be that there's simply no data out there, or it may be that it's there and I didn't find it because I wasn't specifically looking for it. My recollection is that the Sinopharm vaccine didn't perform quite as well in Brazil, for example, as had been advertised by China. But that's not to say that it doesn't work. I think it is a fairly effective vaccine. I just don't know the specifics off the top of my head. I'm sorry. I'm curious, how widely is it being used in Trinidad?
So I don't have the exact data on the top of my head, but it is the most common vaccine being administered. The initial, in the beginning of the vaccine response, AstraZeneca was sort of the only vaccine we had access to. And then came Sinopharm and Johnson & Johnson. And by far, the largest vaccine supply we have is Sinopharm. That's what most people are accessing, at least. And in our own program at MRF, I think out of about 500, maybe odd, in that sort of territory, vaccines, persons vaccinated. I think 200, just over 200 with Johnson & Johnson, the rest were Sinopharm. So there is still quite a, and I think the national figures are even more skewed towards Sinopharm as the vaccine of choice. So I say it's going to be interesting in terms of what data there is, if there is data about Sinopharm in among persons with HIV. One of the things that I think both WHO and PAHO are advocating for all vaccines generally, and you would have touched on this, I think, in some of your earlier comments about need for booster dosing because of waning antibody levels over time, particularly with, I think, live attenuated, killed virus as opposed to the other products. So I saw something just came up, so.
Yeah. I do have like two slides about this, which I can cover very briefly, which are really just the CDC here in the United States has recommended that people with severe immunosuppression, which is things like organ transplant, high-dose prednisone, or other immunosuppressive drugs, cancer chemotherapy, or people with advanced HIV disease, not on treatment, CD4 counts less than 200, those individuals should get what's called a third dose of the primary series. And just to get the semantics right here, the third dose is not the same as a booster dose. The third dose is given like, it's part of the original series. And they're saying, people who are severely immunosuppressed should get as their original series of shots 3 doses instead of 2. The booster dose, by contrast, is to address this problem of waning immunity. Individuals in whom we got a nice immune response with a standard 2-shot regimen, but over time, specifically after about 6 months, now that immunity seems to be fading. And there's actually pretty good evidence around that phenomenon that's come from Israel that clearly, after about 6 months, for a lot of people, especially those over 60 or 65, the effectiveness of the vaccines, specifically the Pfizer vaccine, because that's the one that was used in Israel, that effectiveness drops off. And in Israel, they have very clear evidence of that happening. And it's not just sort of in vitro theoretical. They've seen increased cases of COVID and even mortality among older individuals who get these breakthrough infections. Furthermore, they've shown that getting that booster shot really does boost immunity and provide very meaningful protection against COVID. So based on that, the United States came out and also recommended booster shots for individuals who are over 65 years of age, who have certain conditions that would increase the risk of severe COVID disease. These are things like diabetes, high blood pressure, lung disease. They included HIV in that as well. And it doesn't have to be HIV with the low CD4 count. Any HIV is part of that. We don't have specific data regarding the waning of immunity among people with HIV after, like, say, 6 months after receiving the initial series. We just don't have that level of granular detail yet. We may get that sometime, but nevertheless, the CDC sort of concluded, well, we're seeing this waning of immunity among people who don't have the most robust immune systems, as suggested by the findings from Israel, and we're going to include people with HIV in that cohort who weren't getting a booster shot. And I think that makes perfect sense. So at least here in the United States, and also in the United Kingdom, a third dose, a booster shot, is recommended for those who've completed the initial 2-shot series, who have a health condition, including HIV, that might reduce their immunity, and those individuals should get a booster shot. Or in this case, this was again the third drug. So I think the concept is starting to catch on. We don't have a ton of data specifically for people with HIV, but that's sort of where things stand. These are the details about booster shots that the CDC recommends here in the United States.
Thank you, Dr. Behrens.
Now, Dr. Behrens, when HIV-infected patients have very low CD4 cell count, let's say 100 cells, the viral load is 58,000, they're newly diagnosed and starting treatment, and they ask you whether they should take COVID vaccine. Do you give them the vaccine immediately? Do you wait, or what do you do? What would you recommend?
Well, I haven't encountered that situation, but yeah, I think the point you're getting at is right now they're, based on what I've shown, they may not respond very well to the vaccine. Whereas once they're on ART for a little while and their viral load is undetectable, their CD4 count is hopefully higher, they're more likely to respond. I would probably go ahead and vaccinate immediately, because the threat of COVID is immediate and real. Hope that it has some impact, and then give them another dose a month later, and then give them a third dose a month after that. That's someone for whom a 3-shot.
Hi, hello, can everyone hear us? I think we just disappeared for a little while.
Oh, sorry. What I was suggesting is an individual like that, I would immunize immediately with the first dose. I would give them a second dose a month later of the COVID vaccine, and then I would give them a third dose 1 month after that. All the while they're hopefully on ART and achieving virologic suppression, because with today's regimens, especially dolutegravir based, they often do get undetectable within just within 3 months. Even consider a booster dose 6 months after that. But at least you've given hopefully some protection immediately, and you're giving them ongoing booster shots. Obviously, I don't have a lot of, there aren't a lot of data to back up this strategy. It's just kind of what would make the most sense to me.
Okay. Thank you.
No, maybe just one last quick question. Some of our patients approach us asking for vaccine exemptions. One of the potential reasons for being given a vaccine exemption, other than religious belief, is immunocompromise. I wonder if you could comment on that, because all of our patients living with HIV assume that they're immunocompromised as a result of the HIV status, and you have to explain, well, no, you're not immunocompromised, so you don't qualify for the exemption. And I'm wondering if it even makes sense to exempt people, because the persons with the lowest CD4 counts are at the most risk.
Yeah, it makes no sense whatsoever to exempt someone who's immunocompromised. But their immunocompromised state makes them much more vulnerable to COVID. We know that, and to severe outcomes and death. And therefore, it's actually that much more important that you do whatever you can to protect them, including, of course, giving them the vaccine, because while the response may not be as robust, it's still likely to provide some protection. It may even provide full protection, right? We don't know, the exact details. So, furthermore, there is no evidence whatsoever of increased risk of adverse effects from the vaccine among those who are immunocompromised. So it's not like there's any elevated risk here of a bad effect from getting the vaccine. There's only upsides here of getting some protection. So so I really don't buy that, and I've never bought the religious exemption either. I mean, if to the extent that sort of religion and morality and that kind of thinking applies in considering vaccinations, well, there are these individuals who are severely immunocompromised that they get vaccinated, but they can't necessarily rely on that vaccine giving them protection. So their protection relies on everyone around them getting protected, getting vaccinated, in order to reduce the risk of them being exposed. So to me, it's it's a very sort of at least in virtually all religions, there is this principle of you care for the vulnerable, you protect those who are the most vulnerable in society and those around you. And the way you do that in this situation is by getting yourself vaccinated. The more we all get vaccinated, the more we do. That is the best way we can protect those who are most vulnerable to getting this terrible disease.
And I think that's a very good way to end today's session. So again, I would like to thank Dr. Behrens for his presentation and for the benefit of his wisdom and experience. And I want to thank all the persons who came out today to learn about COVID-19 and HIV, and hopefully we will be able to, put it into our own personal practice as well as serve our patients better, counsel our patients better, now that we have a bit more armamentarium of information with which we can back up our statements. So just a quick housekeeping note, our next session is going to be next week, Thursday, and it will be another HIV session. We hope it's going to be something on HIV cure, which we haven't spoken much about in all 58 sessions. I don't think we've spoken about it today, so I think it's high time that we do. And again, everyone, we shall see you again in a week's time for another session of HIV, mRF, HIV, STI, COVID. Apologies, my caffeine levels are dropping. And I hope you will have a great weekend. Stay safe, stay well, and we'll see you soon.
All right, thanks everybody.